Good evening, everybody. Welcome to Dr.DWIBHASHI Acupuncture Education Series. So, today's topic is on pronator teres syndrome, median nerve entrapment at the elbow. The learning objectives: understand anatomy, causes, symptoms, diagnosis, and management. So, there is a friend, anterior of the forearm, area of the compression between two heads of the pronator is usually seen here, and pronator teres muscle is here. You can see it very clearly. Front anterior of the forearm. Important point. The median nerve passes between the two heads of the pronator teres muscle in the proximal forearm. Compression here can cause pain, tingling, or numbness in the forearm, hand, and fingers. So the key landmarks are medial epicondyle, bony bump on the inner side of the elbow. Pronator teres muscle runs diagonally across the upper forearm. Median nerve pathway passes between the two heads of the pronator teres. Innervation of the median nerve, sensory lateral 3.5 fingers, that is thumb, index, and middle, and radial half of the ring finger. So thumb, index, middle, and the radial half of the ring finger. Thenar muscles and forearm flexors except FCU and medial half of FTP. Common symptoms including aching pain in the proximal forearm, tingling or numbness in the thumb, index, middle, and radial half of the ring finger, weakness in the gripping and pinching symptoms aggravated by repeated forearm use. Median nerve anatomy, force, motor function, and sensory distribution. So here the median nerve arises from the medial and the lateral parts of the brachial plexus, like C5, C6, C7, that is the lateral part, and medial part is C8, T1. So arm, elbow, forearm, wrist, and hand. You can see the sensory distribution in the palmar view, the dorsal view. So and also the motor innervation. Forearm skeleton, radius, ulnar, elbow landmarks. Here is the humerus, this is the radius, this is the ulnar, this is the carpal bones, this is the metacarpal bones. This is the anterior view, this is the posterior view. The olecranon process of ulna is clearly seen here. This is the lateral view. Pronator teres muscles, anatomy and relationship to the median nerve. So you can see the anterior humerus, medial condyle, pronator teres muscle. Here it is the pronator teres muscle. The median nerve, brachial artery, radius, and ulna is shown here. Origin insertion, medial epicondyle of the humerus. Insertion lateral surface of the radius. So this is skeletal landmark. Actions include pronation, turns palm downward, weak elbow flexion, median nerve C6, C7, ulnar artery and radial and anterior ulnar recurrent artery. Efficient compression of the median nerve near the pronator teres muscle. Causes repetitive pronation, gripping, sports, manual work. Risk factors include repetitive activity, poor ergonomics, diabetes, previous trauma. Symptoms include forearm pain, numbness, tingling, weak grip. Comparison: pronator teres syndrome versus you can have to see carpal tunnel syndrome, which I have already explained. Clinical examination include inspection, palpation, sensory, and motor testing. Pronator compression test. Pressure over the pronator teres may reproduce symptoms. Here, apply firm pressure here. You can see the typical area of symptoms will be shown in these 3.5 fingers. So the patient must be seated, shoulder erected, elbow flexed at 90 degrees, forearm in neutral position, wrist in slight extension. Then only you can see. Okay. So positive test, reproduction of symptoms in the median nerve distribution suggests as compression and irritation of the median nerve at the pronator teres. Resisted pronation test. Resisted forearm pronation may provoke pain or tingling. Pronation and downward resistance. You can see the positive test, reproduction of pain in the proximal forearm or symptoms in the median nerve distribution during resisted pronation. So, to reproduce pain or discomfort in the pronator teres muscles during resisted forearm pronation suggested median nerve entrapment at the level of the pronator teres. So, the same thing, but patient is seated, shoulder erected, and elbow flexed at 90 degrees. Forearm in neutral position, thumb positioning up. You can see the thumb positioning up. Wrist in neutral. So how to perform? Ask the patient to pronate the forearm, apply downward resistance just above the wrist while the patient attempts to pronate, maintain resistance, observe for pain and proximal forearm or reproduction of symptoms. You can see the median nerve distribution. So this is the median nerve gliding. Gentle nerve glides under guidance. Start position, shoulder abduction, elbow extension, wrist extension, and neck extension away. Return. So we promote normal mobility of the median nerve, reduce nerve tension, and improve symptoms. 8 to 10 repetitions, 2 to 3 sets, 1 to 2 times per day. Benefits: it improves median nerve mobility, reduces nerve tension, helps relieve pain, tingling, and numbness, improves functional movement. So guidelines is move slowly and smoothly. Stop at the point of the mild tension. Do not push into pain. Breathe normally. Perform both slides. Investigations, clinical assessment, nerve studies, imaging when indicated. Management includes activity modification, rehabilitation, medication when appropriate. Role of acupuncture may be considered for selected patients as a part of comprehensive care. Prevention, ergonomics, breaks, and conditioning. Key takeaways, early diagnosis and individualized treatment are important. So thank you very much. We will see you tomorrow.